All right, we've got a good one today. I've got Dr. Jehni Robinson. She's a professor and chair of the Department of Family Medicine at the Keck School of Medicine at USC. She also serves as Associate Dean of Primary Care. She went to Stanford undergrad. She went to Morehouse Medical, and they have been on the front lines where she is now in terms of providing medicine in different ways. We're going to talk about street medicine, the work that they have done with the homeless. And at the end of the day, I think you're going to get a great deal of information about what COVID has done to medical models, and where we go from here, how it's changed the game, even if it's over tomorrow. A very thoughtful conversation. I think you're really going to enjoy it. Dr. Robinson is really fantastic. So strap on up. Here we go. Well, I am so thrilled to have, I don't know where I go after I start with this guest. And while I can say in full disclosure, she's family, from a professional standpoint, I can't think of anybody better to talk about a very relevant issue, something that's happening with us all right now. I've got Dr. Jehni Robinson, who is the chair of the Department of Family Medicine at USC, and the Associate Dean of Primary Care for the Keck School of Medicine at USC. Dr. Robinson, how are you?
I'm good, and it's a delight to be with you today, and looking forward to our conversation.
Yeah. Oh my God. Thank you so much. I know it's early too, so I really appreciate that. So let's talk first about your process. I mean, you've got pages of qualifications and things like that, but talk about your process and how it had you arriving at family medicine.
Sure. So I think I was very influenced by my parents, who each in their own way used their career to help others. As you know, my dad worked with Dr. King. My mom is a psychologist who was always using her career to help children and families. And I was raised with a strong belief that you use your career to help others. So that was sort of unquestioning for me that I would seek a career, and medicine allowed me to make a difference, to help people, families, and communities. And I think that orientation really drew me to family medicine, where our specialty is in its breadth. So we take care of everyone from baby to grandma. We can take care of 90 to 95% of the needs of the people we care for. And we're very thoughtful about care for our patients in the context of family and community. Right. And so that broad scope and that ability to have longitudinal continuity relationships with my patients and their families over time, that was very appealing to me.
Right. Wow. So kind of in a follow-up to that, give us the 30,000 foot view of what a doctor in family medicine, and then we'll talk about you being an administrator as well, what a doctor in family medicine is really looking to accomplish in their job. I mean, at the risk of asking you a very broad question, but what do you see when you're talking about we need to provide care, we need to take care of baby to grandma? Well, tell me about some of the hows and some of the things that you see that way.
So I think the biggest piece is our orientation towards comprehensiveness and holistic care. So we know that the range of health concerns for an individual, family, community can be very, very broad. So everything from preventative, which we have a strong focus on, because where we can prevent problems, so much the better for so many reasons. Right. We can take care of acute needs like a cough, a cold, an infection, a chronic need like diabetes or hypertension, mental health needs, as we talked about preventative care, immunizations, vaccines, screening tests to prevent disease. And so we're looking at all of that. But because it is so broad, our orientation must be with the patient at the center. Right. And we develop relationships with patients, help them inform us about what the priorities are for their own health. And then we can follow along accordingly and help prioritize what might be most important for that individual in terms of their health, both for whatever they're dealing with in the moment, but also looking forward and ahead as to what might be a threat for them down the line.
Right. Wow. So I guess I have to ask you, you went to Morehouse Med, and I wasn't there at the law school graduation, but I saw Colin Powell handing you an award. And tell me what they taught you about pandemics and to what extent you could have imagined with all the preparation in the world that you would be seeing this once in a lifetime thing. Did you ever look at something like this through the window? Could you?
Yeah. My educational background, as you mentioned, I landed at Morehouse School of Medicine for my medical degree. I did my undergraduate at Stanford. And I think having that contrast of experiences was wonderfully informative to me in terms of my learning and training. What was really impressed upon me at Morehouse School of Medicine is the importance of community, is the importance of how we have, again, reinforcing why I went into medicine, an obligation to use our skills to help individuals and families to help improve the health of communities. Now, pandemics specifically, I don't recall being 20 some plus years away from medical school now, the specific education that we had on pandemics. But I can tell you that until COVID-19 happened, that certainly we were aware of the threat in the background, and we had seen, the movie Contagion, and knew that this could happen. We're aware of that theoretical threat. It wasn't something that was front and center, and it certainly wasn't something that we were actively reading and learning about. I talked about the breadth in our specialty. The things that we see most commonly are not pandemics.
Right.
And so certainly we were probably not as prepared as we needed to be. I think even individually as physicians, but of course, as we probably will get into, more importantly, the community and our nation, as we should have been to appropriately face the threat.
What made you know that this was really real and this is happening right now? Was it a particular moment or?
I think we started to watch what was happening in China. And I think it was really frightening to see how everything was locked down, how people were dying. And I think there was a lot of fear. I think we all went through a piece of denial. My daughter will say, I remember at the beginning of this, you guys were saying, well, this is like the flu. And actually, maybe it's not as deadly as the flu. And we should be more worried about the flu right now. So I think we went through a period of denial. But I think when the young Chinese physician advocate who was in his 30s died, I think that was the moment that we all woke up and said, wait a minute. A young physician in his 30s should not be dying. What is happening here? And an advocate should not be dying. What is happening here? And I think we started to feel the realness of the threat and how it might be able to impact us in the future.
What did it do? You have an interesting perspective, not only as a family physician, but also as administrator. So what did it do to you guys' playbook, just in terms of saying, there's always the matter of we want to be able to treat people, we have breadth, et cetera. But from an administrative standpoint, it's also a matter of, here's how we, create the opportunities. And I know that you are involved in some interesting programs in terms of, delivering medicine, street medicine and some of those types of things. What were some of the challenges that you see, not only as a physician, but as an administrator to deal with what kind of came out of, a relative nowhere, but certainly was kind of a, medical tsunami, for lack of a better term?
Yeah, it's a great point. I mean, I wear a number of different hats, but probably the one that takes up the most of my time is that I'm chair of the Department of Family Medicine and Associate Dean for our medical school, Keck School of Medicine, for primary care. And so I wear a large administrative hat, and the bulk of my time is spent on administration and leadership. And I think that those roles in a time of a pandemic are critically important to focus on and do a good job with it, because we needed to radically transform our system of care to be able to care for people who were possibly infected with COVID-19, to keep our employees safe, and to be able to respond quickly and nimbly to consistently changing information that was coming in. And I'm a big believer, I teach our medical students as well. And one of the lectures I give talks about systems of healthcare, because I really believe you can be the most amazing physician, incredibly well skilled, but if you're in a system that doesn't serve the patients and serve you well, you will not be successful. So I strongly believe the role of administrators and leadership is to create systems that allows every individual in that system to function optimally and to be doing their best, to be giving their best, and to be feeling safe and protected, knowing that they can show up and do their best for the patient, and that their own health and the health of their own family is also going to be protected. So this was a tremendous challenge. And in my role as chair of the Department of Family Medicine, I'm also president-elect for our USC Care medical group. The dean reached out to me and asked if I would be a conduit between the School of Medicine and Keck Medicine, our health system, to be able to be sharing that information back and forth. So I sat at a lot of meetings and had the fortune of watching a lot of leaders in action. And I have to say, really doing an excellent job trying to balance, how do we make sure that we have enough personal protective equipment for our employees? What is the right kind of equipment for them to have? And also knowing that we don't know how long this is going to last. How do we balance conservation with having people feel protected on the front line? And this was a decision and a conversation that evolved over time as new information came in. And it was really important also for the leadership to be listening and hearing the concerns from the front line, and then modifying and changing the policies as we went to make sure they were addressing the needs of those who are on the front line taking care of patients who might have COVID-19.
It's certainly been interesting to have conversations with folks that are dealing with delivering service every day and those types of things. As you've gone along here, tell me about some of the pleasant surprises that you've had, because I know for some time, once it became apparent something was really going on here, there was a preparation for the worst, for lack of a better term, right? Tell me about some of the prizes, some of the surprises, the pleasant surprises that you've had, and then maybe a couple of the challenges that, despite your best planning, once you knew that this was how urgent it was, other things that are new problems that really you weren't necessarily expecting to see.
Yeah. I think I was really delighted at how people came together. I remember in the early days, a very quickly called meeting. Everyone got in a call 6, 7 a.m. the next morning. Everyone was on the call in terms of administrative representatives to talk about how we rapidly shift to telemedicine. And within 20 minutes, everyone on the call was like, yes, we have to do this. We have to figure it out. We need to go there and go there quickly. And compliance and legal and all of the different entities that are looking at the various aspects of this were lockstep, let's make it happen. And we rapidly deployed telemedicine, which is a video call, kind of like a Zoom call that we've all gotten so used to, where we're providing medical care. And we have learned so much about how to do that, but how quickly we could rapidly deploy that to let our patients know we're still here for you. We're still available. It looks a little different. We're trying to keep everyone safe. Was incredibly impressive. The innovation, the collaboration. In some settings, you feel like the rule book was just thrown out the window. And forget the old rules. Let's just get together and figure out what we need to do right now to take care of our patients and our people. So that kind of collaboration and innovation was wonderful and surprising. And I think also that inclusivity, we care about everyone. So we started a Care for the Caregivers program to address the issues around frontline healthcare workers not wanting to go home at night, worried about bringing home the COVID-19 potentially to their families. So there were hotel rooms that were arranged. And I saw that program evolve from, it just got wider and wider and wider in terms of who could take advantage of that, making sure the residents could take advantage of it, making sure people working at our county hospital right next door could take advantage of it. And so the way that we cared for each other and the inclusivity in that and the connectivity in that was really heartwarming. So those were some of the surprises. I think some of the challenges were figuring out how do you move and change and put processes in place, and then you get the process in place and new information is coming in. How do you rapidly communicate and disseminate that? And how do you help people deal with the uncertainty and the fear because we don't know what's going on? So all of the uncertainty and all of the change is very hard. And so how do you help people deal with that? And we found that regular, frequent communication, that's two-way. So we're talking, but we're listening.
Right.
It's critically important in times of crisis. And I think we've done a good job with that. One of the other challenges I wanted to come back to, you had talked about our street medicine program, and I didn't get into that, but
right. Yeah, I was going to ask you about that.
I'll tell you again in my breath and the way that I look at things, in one sense, it's very simple. I believe everyone deserves access to high quality primary care, no matter where they are.
Right.
And
including homeless, right? Yeah.
Employees, right. Whether they're homeless, whether they're living on the street. And we have a street medicine program that we started about a year and a half, 2 years ago now, that believes that we need to bring care to people, because people, for a whole variety of reasons, often don't come to us to seek care. It's a profound flipping of the model.
Sure.
For years, we've said to homeless people, here's a clinic, go to the clinic. They don't go. Right. And again, so bringing care to people is the street medicine program. And we could do a whole session on that. But in terms of the COVID-19 crisis, I think one of the things that's been really challenging for us is how do we respect the principles and the foundation of that program while addressing the COVID-19 pandemic and the risk to this population, while also keeping that risk in perspective with everything else that is confronting one of our most vulnerable populations. So there's been a move to take people from the street and house them, which we wholeheartedly want people to get housing. But we also know that we have to start with people where they are and what their needs and priorities are. And that if we don't do a good job with that, we can rapidly house people and then have them rapidly back on the street and not have people better off than where they started. So figuring out how do we have a thoughtful approach in a time of crisis when you have maybe resources available to get people housed that you didn't have before has been incredibly challenging to figure out how do we do what's right by people in a way that's thoughtful of them and their needs and their preferences and their priorities.
How do you see this whole conundrum of testing? The ability to test, to be able to have more tests available, the quality of the tests, how has that evolved in this past 2 to 3 months, and where are we on it from what you see?
It's a great question, and it's a huge challenge right now. And we have had many, many discussions, and we'll continue to have many discussions about testing with, touching on all of the issues you mentioned. Access, how good is the test? What does it mean? What does it predict? What does it not predict? What does it not tell us? What do we do about false negative tests and false positive tests? There's a lot involved with this. I have to say, I think some of the most brilliant thinking is sometimes really clear and simple. And I think the simple answer on this is our testing by itself is not good enough to inform a strategy about where we go. Sure. It's part of an overall strategy, but by itself, it can't be a strategy. And so I think we still need to go about our business assuming and presuming that everyone could be positive. So if you take that framework, it informs a whole other set of things that you need to do in addition to thinking about testing. So staying at least 6 feet away from people and maybe more.
Right.
um,
Right.
Trying to wear a mask and use the appropriate mask for the appropriate circumstance. Doing good hand hygiene frequently, and that includes things like not touching your mask and taking it off and washing it and cleaning it, appropriately. And then screening so that, outside of our hospitals, for instance, there's a series of questions that everyone is asked about symptoms and exposure. We've been taking temperatures to try to make sure that we're not letting people into our healthcare setting who might have symptoms. And we have other strategies to make sure that we still care for those people, that we're not just turning them away. So I think testing can, and I can say a little bit more. We've been doing point of care testing where we're checking for PCR and antibody amongst our healthcare workers and starting with those most at risk.
Yeah.
And what I can tell you is that the rates of infection and of antibodies are very, very low in terms of the results of the test.
Right.
I think it does tell us that comprehensive strategy that I described is working to prevent infection. But I think it also tells us some of the limits of testing. So what does that mean? Particularly if there's still some of those tests that might be a false negative.
What have you been able to do connected to the wellness of your frontline folks related to their mental wellness? How have you, as an administrator, looked through that window and figured out, because the one thing I really want to dispel is that, whether one gets COVID-19 or not, or whether they've been personally affected, this is very real and it's affecting a lot of people and it's changed a lot of lives. So how have you been able to help your folks on the mental side, being okay with coming to work every day and those types of things?
I'm so glad you asked that question. I mean, there was a study in Wuhan that looked at physicians and nurses who were frontline and found that 50% were having significant challenges with depression and anxiety. So this is a very real concern.
Wow.
And part of the Care for the Caregiver program that I talked about earlier that has hotel rooms also has mental health services that are available not just for our frontline, but really for all of our staff, and not just for our faculty and staff, but also for their families, because we realize the impact of this is really widespread. And so we have different support groups that are available. You have on-demand access to mental health services from our psychiatry department, who's really led this and been incredibly generous with their time in terms of trying to ensure the well-being of everyone. And then for myself as a leader, what I have done is we have a weekly meeting with our department, with our faculty and staff.
Right.
And every meeting we are talking and sharing updates, so good communication back and forth. I spent one meeting really going over all of those resources in detail, to really talk about the availability and to normalize that we are all struggling and that it is important to access the resources because there is so much stigma around mental health that we have to deal with. And then the other thing we've done in our department is a daily inspirational newsletter that goes out via email.
Yeah.
And we share all kinds of things, all kinds of tips and strategies, how to work from home effectively, how to take breaks, how to manage stress during this time. So we're trying to really put out resources, but again, also encourage two-way communication and share each other and maintain that connectedness with each other, which is so hard when you're working from home.
Wow, that's huge. Well, this has been fantastic, but let me ask you this last question. If COVID was over tomorrow, it's not. There's potential that there could be a second wave, and I'm as optimistic as everyone else about a vaccine, but that would be record time if it was actually ready by the end of the year. Then there's the matter of people actually having it, being available to, despite the fact that people can go back and forth about how much, and we'll know, time will tell how much COVID will continue to affect us and things like that. Even if it was over today, it seems that talk about how COVID has changed the game in terms of how you look at care, how you look at delivery, how you figured out this works really well what we're doing here, and maybe we need to go to the drawing board there. How has it really become a game changer in terms of what you see as a family medical provider, family physician, as well as an administrator?
Yeah, you're right. We are forever changed. And we are not going back to the way things were and how we deliver care. And we are actively trying to figure out what the new normal looks like. Telemedicine has been wonderful. Mm-hmm. And I don't, and we've been talking about this, by the way, even long before COVID. We had a pilot going.
Right.
Now we adopted just so fast.
Yeah, sure.
And we're not going back. It's so convenient for patients not to have to leave their home, not to have to drive traffic, fight parking, the stress if you have mobility issues in terms of, trying to navigate our medical buildings.
Right.
We're going to continue doing telemedicine. What percentage of that is still unclear, but I think we're learning a lot about how we can provide care. So I think we're going to really be using technology a lot more to keep us safe.
Sure.
This idea of big crowded waiting rooms in health centers is gone.
Right.
We can't do that. It's not safe.
Right.
So how do we get you in, get you out? I hope, and it's my goal and desire, right, that this is going to make healthcare better. However, we have to always keep our eye on the significant health disparities that we have in our country, which have again played out with COVID-19, but we're not new with COVID-19. We've known about disparities in life expectancy and how different illnesses affect different segments of our population. Right. So it's really critical that as we move towards technology, we make sure that we also have our eye on access and that everyone can access the new way that we're delivering healthcare, and that we're going above and beyond to be thoughtful about people's language considerations, what people have in terms of technology, how they access it, I think is also going to be critically important for us to look at.
Wow, fantastic. Well, Dr. Robinson, Keck School of Medicine, you are the truth. Thank you so much for spending time with me on this early morning. I won't say the day of the week because I don't know when we're going to release this, but I thank you so much, and best to you and your family and to everything that you're doing over there at USC.
Thank you, Joe. Always a pleasure to talk with you, and good luck with the podcast.
Thank you so much.